The clinical swallowing evaluation or bedside exam is an initial assessment of factors that relate to the swallowing status, and it helps to determine the need for further instrumental assessment. The three main components of a clinical swallowing evaluation include case history, an oral mechanism exam, and observation of swallowing competence with test swallows on various liquids and there are 5 reasons for performing a clinical swallowing evaluation. To define a potential cause located in the medical history, to establish a working hypothesis that defines the disorder, to establish a tentative treatment plan which should be reassessed daily, to develop a potential list of questions that may require further assessment, and to establish the readiness of the patient to cooperate with any further testing. The supplies needed for the clinical swallowing evaluation, which includes the oral mechanism exam, are gloves, a flashlight, a tongue depressor, ice chips, a spoon, a cup of water, a straw, applesauce, mixed fruit, crackers, and thickener.
Prior to conducting an oral mechanism exam, you will want to gather a complete case history to develop a better understanding of the patient. These include questions regarding the patient's chief complaint, current nutritional means such as NPO or PO, type of bolus complaints such as liquids, foods, or pills, the onset and progression of their swallowing difficulty, any pertinent medical history, as well as their current medications.
Next, you will perform an oral mech exam to assess range of motion, especially of the tongue, strength, symmetry, coordination, and sensation of oral structures. Additional information gathered from the oral mech exam include breath support, resonance, and volitional cough.
The main things to look for during a clinical swallow evaluation include appropriate swallow initiation, hyolaryngeal elevation and excursion, number of swallows per bolus, and signs and symptoms of aspiration. Swallow initiation timing should be less than 1 second on thin liquids, and you also want to assess for any signs or symptoms of aspiration before the swallow. And a delayed swallow initiation may indicate sensory deficits. Hyolaryngeal elevation and excursion can be assessed by palpating the patient by placing one finger in the space right above the hyoid bone and one finger on the thyroid notch, and then examine how much, how fast, and how consistent the larynx moves upward and forward during a swallow. If a patient has poor hyolaryngeal elevation and excursion, then you may suspect them having difficulties with UES opening and epiglottic inversion. You also want to count how many times a patient swallows per bolus. Typically, it only takes 1 swallow to clear liquids, 1 to 2 swallows on soft moist foods, and 2 to 3 swallows on thicker consistencies. Increased swallows may indicate poor bolus and or residue clearance. Other things to look for during a clinical swallow eval include feeding skills from a spoon, cup, and straw, lip closure, bolus preparation and transference, and coordination of respiration when eating.
Some important signs and symptoms of aspiration include a change in voice. For example, a wet voice will sound garbled, or the patient's voice will sound like there is mucus in his or her throat. This can be a sign of silent aspiration and can also indicate uncleared residue. Vocal hoarseness can also occur. Throat clearing after the swallow, which is a response to residue, coughing or choking following the swallow, changes in breathing, such as shortness of breath or a rattling sound during breath, watery eyes, facial grimace, fever spikes, and if someone does not cough or throat clear reliably, this is also a sign that he or she could be experiencing silent aspiration. Following the oral mech exam, you will begin to test the patient's swallowing abilities, beginning with a saliva swallow or dry swallow, to make sure the patient can manage his or her own secretions before moving on to further liquid and food trials.
If the patient appeared to do well doing a dry swallow, You may give the patient ice chips, and after the patient swallows, listen for any throat clearing or coughing, as well as changes in their voice, such as a wet voice quality, by having the patient say "ah."
If the patient did well on ice chips, you may proceed to water trials by having the patient drink from a spoon, then a cup, and then a straw. Note if the patient has difficulties after each trial. If the patient is having difficulties with thin liquids, progress to nectar and then honey thick, or make an immediate referral for an instrumental exam. If the patient is doing well, increase the difficulty by asking them to take larger consecutive sips.
Following the liquid trials, you will move on to food trials by starting with applesauce and then canned fruit. Remember to check for the vocal quality changes due to the residue buildup, as well as have the patient cough after the swallow to assess the strength and effectiveness of their cough.
If the patient does well, proceed to the soft chewable trial by having the patient swallow a cookie or cracker. Remember that you may need to offer the patient a thin liquid wash in between trials to help with residue clearance.
Some things to remember when conducting a clinical swallow evaluation are instructing the patient in various compensatory strategies that may seem to be helpful, such as the chin tuck or head turn, the bolus hold, or the effortful swallow. Remember to stop the evaluation if the patient is showing any signs or symptoms of aspiration or is having difficulty clearing residue after multiple swallows on a certain bolus consistency.
Some limitations of the clinical swallow evaluation are: it does not provide internal view of anatomy, does not provide indication of severity of residue, it cannot detect when aspiration is happening and whether it is occurring before, during, or after the swallow, it does not assess PES function, it does not give a good view of premature spillage or epiglottic inversion, and it cannot detect silent aspiration. The clinician must rely on outward signs to detect silent aspiration.
After a clinical swallow evaluation has been conducted and it has been determined a patient needs an instrumental exam, you must decide between a modified barium swallow study and a fiber optic endoscopic evaluation of the swallow. MBS better assesses penetration and aspiration during the swallow, as well as the amount of aspiration, epiglottic inversion, oral stage problems, esophageal problems including globus sensation, premature spillage, and bolus propulsion. MBS is often performed on those patients who cannot tolerate a FEES exam. FEES better assesses aspiration after the swallow, vocal fold and arytenoid movement, velopharyngeal closure, the ability to achieve airway closure, pharyngeal and laryngeal sensation, secretion management, pharyngeal wall symmetry and strength, anatomical abnormalities including edema, premature spillage and residue, and gives a better visualization of penetration. FEES can also be used as a biofeedback tool for teaching swallow strategies to patients.